What a lovely sight this is to see all of you here. Thank you all for coming. And welcome to our 5th Symposium on Diabetes and Humanitarian Crises. For those of you who I haven't met yet, my name is Sylvia Kalenbrink. I'm the director of IATA, and I'm an endocrinologist at Mass General Brigham, based in Boston, and with the Harvard Humanitarian Initiative. So it's a true privilege and an honor to have you here today. And I want to start by thanking our co-hosts, the London School of Hygiene and Tropical Medicine, Centers for Chronic Global Conditions, then Mass General Brigham, and our sponsor, the Helmsley Charitable Trust, and James Reed, Program Officer for the Type 1 program, for being here today. He's been a tremendous partner to many of us in this room. Thank you also to Sarin Events, the event planning team, Tracy and Bonnie, who you'll see running around. There's Tracy back there if you need anything at all. They've been terrific in helping us set up. And also to Anna Nakayama, our program manager, who's worked tirelessly behind the scenes to make this happen. So let's give it up for Anna, just that we're all here. And I'll take this opportunity also to introduce you to Kelly Lai, who actually just started on Monday with IATA. She's a new program coordinator who will be working with us to help Anna and our team with all the work behind the scenes. So if you see her, please say hi. Let me move here. So this was a year and a half ago in Athens at our 4th symposium. And it's hard to really wrap your brain around what has happened in our world over the last year and a half since that time. It's been whiplash, I think, for most of us in this room. It's been a very challenging past 9-10 months, especially for most of us, I will say. And the humanitarian principles have been very much under threat. And so it's all the more remarkable to me that you're all here today, despite all of these challenges, all of the cuts, the resource constraints. That you're here means a lot. So thank you for coming. It speaks really to your dedication and I think the importance of this topic that we're all here today. I also want to say on a positive note, I think we've all been very encouraged and cautiously very optimistic about the recent ceasefire between Israel and Hamas. And there was some news media going around by Dr. Tedros over the last few days about the insulin shipments that have been going into Gaza. And so we hope and we pray for continued peace, for healing, for the resources that they need there to be, for those that need it to be received. Yet, despite, all the global challenges, all the funding cuts, all the staff constraints, the issue of diabetes remains, a great challenge and is not abating. It doesn't stop. And unfortunately, I update this slide every 6 months or so, or these set of slides, and the numbers just continue to go up. The global prevalence of diabetes continues to rise in every single global region, every country of the world. No one is immune. The vast majority, of course, living in lower and middle income countries. And some worst case scenario estimates suggest that over 1 billion people could be affected by diabetes by 2050, especially earlier onset diabetes at younger ages. And I'm sure you're very well familiar with these numbers, but the numbers of forcibly displaced people globally continue to rise every year, unfortunately. The vast majority also in lower and middle income countries, and the vast majority in protracted crises. In addition to conflict-induced displacement, there's displacement due to climate change, natural disasters affecting about 200 million people each year. And there is another worst case scenario estimate suggesting that 1.3 billion people could be displaced due to climate-related crises by year 2050. So this is really the convergence of extreme risks, particularly for people living in lower middle-income countries that are going to be very hard hit by diabetes and also climate-related and other disasters over the coming decades. But really no part of the world is immune. And so we have our work cut out for us. And yet, with the current global situation as it is, we have to be able to do more with less at this point. We have to think creatively, how can we address these challenges with the current humanitarian landscape as it's evolving and as it's been changing. And I had the great honor last week of meeting Dr. Tedros, the Director General of the WHO. He was in Boston for the Harvard Humanitarian Weinstein Award. He was awarded that award, which we give out, I think, about every year. And so we got to spend a couple of days with him, and I was so encouraged by his words. I mean, here he is leading the WHO through this extraordinarily challenging time, and his kind of message of hope and positivity, and saying, you know, how can we use this moment and these challenges as an opportunity for the betterment of humanity? How can we work together to find new ways of working together? And he talked about the importance of the collective, of solidarity, and that we all here now also in this room have the opportunity to meet the current challenges, to be part of the solution and moving forward and not giving up and persevering. And so I think that's what we're here for today, or the next 2 days, is to go through the agenda we've outlined over the last, I guess, 6 years now, since Boston in 2019, when we we wrote the Boston Declaration together, outlining our common agenda. That then was updated in 2022 in Krakow, where we reevaluated those goals and updated kind of our collective working plan. And so we want to revisit those goals now, again, 3 years later. And as IATA's updating, we're updating our strategic plan for the next 5 years to get all of your input to find what goals should we all be striving for over the coming years as a collective. What agenda can we all get behind and have a shared vision and all work together to achieve those goals? So this symposium is not meant to be one where you just listen and sit back, but where you're actively engaged and participate in conversation. And we have we've a couple new elements this year. So the first, I will hand it over to Lillian shortly to introduce our keynote speaker. But we have 2 plenaries this morning then, one on the current funding landscape and the challenges to have an initial conversation, very much recognizing this is still an area in flux. I don't think anyone has the answers yet, and there's a lot of uncertainty, but having a conversation about the funding changes and implications for diabetes care and crises. And then one around, there's been a lot of high-level commitments and resolutions and meetings over the last year, especially working up to the UNGA, and so how do we turn those commitments into action? We then have a more clinically oriented panel on diabetes and pregnancy, where we'll be talking about, it's a first for us as a group to start addressing, but it's very important. And then a workshop around engaging people living with diabetes in the humanitarian response. And so everyone's going to break out into small groups. There'll be a person living with diabetes and a humanitarian implementer together to lead a conversation around what's the current situation and how can we do better moving forward. And then tomorrow we have a research session, also breakout sessions. I think on the back of your name tag you should have what group you're in for the breakouts. For the research session, Aveen, we'll announce that tomorrow. We've pre-selected groups of mixed individuals from different backgrounds to be part of these little research workshops to set a research agenda together. Then we'll have a plenary on nutrition and food security, also a first for us, so an initial discussion with different speakers bringing different perspectives. And then at the end, the second half of the day tomorrow, we'll have breakouts according to our working streams to, again, review the Krakow outputs see, what needs to be adjusted or added or removed, and where do we want to go from here. And then we have a cultural dinner. It will be at Edelweiss restaurant with Swiss music and dancing and fondue and apple strudel. So I hope you can all come. It's going to be a lot of fun. But before I hand it over to Lillian, I wanted to show this video that just brings us back to why we do what we do and bring the voices of those, that for whom this is all about to the forefront.
أنا حالياً بحتاج 3 أقلام أنسولين شهرياً، لكن حالياً بسبب منع دخول الأنسولين حالياً بس بستلم قلم أنسولين واحد، وهذا الإشي بشكل خطر على حياتي.
In Zimbabwe, living with type 1 diabetes is already a crisis long before a crisis or pandemic hits. Most families can't afford insulin, test strips, or the food that supports diabetes care. When COVID-19 came, it made things worse. People with diabetes were left invisible. No emergency ever included us.
Living with T1D in the Philippines will mean choosing. Do I inject insulin today, or do I eat today? When disasters and climate change hit, like flood, fires, earthquakes, T1D becomes a triple threat. No insulin, no home, no peace.
Hurricane Helene brought extreme devastation, flooding, and damage on a historic level. I can directly speak on my experience when it comes to attaining insulin. It's a challenging process to navigate. And during the time of crisis, a lot of people had gone without.
I never imagined diabetes would change my life, but it did through the loss of my grandmother. Even if we had known earlier, insulin was too scarce, too expensive, and simply out of reach.
Todos os nossos acessos de saída da nossa cidade foram fechados.
Isso me deixou muito ansioso, sabe? Me deixou preocupado, porque as farmácias perto de casa, até um pouco mais distante, nenhuma tinha nem previsão dessa insulina chegar.
In 2024, Pakistan experienced insulin crisis because of the earthquake and the floods. During one of these crises, I was without the insulin for at least 48 hours. No person with the type 1 diabetes should be forced to suffer due to insulin shortage and inconsistent supply.
Kendi korkunçluğunun yanı sıra bir de kronik hastalığımın bana yaşatabilecekleri konusunda da çok büyük korkular yaşadım o dönemde. Çünkü elimde yeterli insülin ve yeterli malzeme yoktu. Yani hem besin konusunda hem ilaç konusunda çok büyük sıkıntı yaşadım o dönemde ve tekrar.
We need awareness. We need real investments in health. For me, a lack of insulin during an emergency was an emergency.
For me, insulin during emergency was an emergency.
For me, access to insulin in a failing economy is an emergency.
We need your help making basic medicine a human right.
Yes, so thank you to everyone who shared their stories. Thank you to Mohammed and Serene for helping us pull this together. These voices remind us as to why this work is so important. And with that, it is my great honor to introduce Lillian Kiapi, who we are very fortunate to have as the chair of the board of IATA. She is a leader and a force of nature in the humanitarian sector, having worked for the IRC for many, many years. I'll hand it over to you.
Thank you so much. Sylvia's already introduced me, and I'll be very brief. It is a great honor to welcome you all to this 5th IATA Symposium, both here in the room in Geneva, but also online. On behalf of the IADA board, I extend our warmest greetings and sincere appreciation for your presence here today and over the coming days. I want to acknowledge the tireless efforts of our colleagues at the IADA Secretariat that have made this symposium possible, as well as the support team that has been in the backgrounds of this. Your commitment to the success of these annual symposiums cannot be taken for granted, so we are really grateful to you for the work that goes into this. So this year's symposium brings us together at a pivotal time. Around the globe, we are seeing humanitarian actors facing unprecedented combination of challenges. We're seeing protracted conflicts, we're seeing climate-related emergencies, and the growing strain of health systems. Health systems are expected to do more with less resources. And yet, amid all these pressures, we also see extraordinary efforts from many of us here today, but also our colleagues, thousands of our colleagues around the world. And we're also seeing resilience from the clients that we serve. And at times like these, gatherings like this symposium are even more important. We share ideas, we discuss challenges, and we encourage each other and recharge our batteries, which is really, something that is dear to my heart. So thank you for being here and for your unwavering support and dedication to advancing diabetes care in humanitarian settings. And I wish us all a really productive and inspiring symposium. So as we begin, it is my humble duty to introduce Dr. Bente Mickelson, our keynote speaker for today. So Bente, as we all know her, is well known for her work at WHO, where she was director for the NCD department, and she was really instrumental in integrating NCDs into humanitarian settings, in low and middle income and fragile settings. Bente has championed continuity of care, access to medicines, and financing for NCDs in low and middle income countries, as well as fragile settings. She co-led the high-level technical working meeting on NCDs in humanitarian settings in February last year, and she's a strong advocate for NCDs in humanitarian settings and a long-standing supporter of IADA. Bente continues to be engaged in strategic planning, health systems management, and serves on boards and steering committees of organizations working on NCDs. So it is my pleasure to welcome Bente.
Good morning, everyone. It's excellent to see so many friends and capacities. You know, when Sylvia asked me to do a keynote speech, I was thinking, why should I do that? And actually, it's a serious question because I just came out of a meeting in Berlin on war and peace. And of course, I heard all the stories of victims all over the world, but also now what we see with frontline workers in emergency and in crisis. And then you go back home and you think, okay, so what have I done? What can I do? I'm not a frontline worker. But then I come to terms, and actually we had a discussion with some of you earlier on this as well, and that will be my sort of main message. We all have a job to do. We just need to use the position we have, whatever position it is, and try to influence so something is happening. So when you're thinking about what's happening today during these days, just think about what can I do with my resources. I think that's a good lead. So from the same meeting in Berlin, Petra Kuri from IFRC said health is the first victim of any disaster and conflict. I think that is something to think about, but also thank you for the messages from the people with lived experience, because actually not having insulin is for them an emergency. So I think we need to think broader. And what I took from the UNGA in these kind of depressing times is some hope. And I want to share them first because I think it's important for us to think about it. Because even if the World Economic Forum Global Risk Report rated armed conflicts as number one for the first time in history, even if we have fragmentation, polarization, sudden cut in aid to the vulnerable, what I heard from the leaders was something new. Many, especially the African leaders, they said, okay, this is a time where we can sit down and cry, or we can roll up our sleeves and take the challenge. And that was really the buzz of UNGA. That was the buzz of also the World Health Summit. And this is something we have, I think, preached a little bit in the diabetes and NCD community. It is about taking charge, using the tools, but start now to try to also mobilize resources in your own country and do it your way. That's also very important. It's not my way, it's not your way, it's the people living there, it's their way. So this is something I think is a hope, and of course I was very encouraged also learning that Dr. Tedros made the point of insulin to Gaza. And you mentioned all the figures, Sylvia. I also had them, because that's another way to, connect to your own, let's say, heart and soul, is to really think about these figures, because I think it's impossible to really understand this. Over 2 billion people are estimated to live in fragile, conflict-affected settings, and 468 of those are children. It's impossible almost to think about it. I come from a country with 5.5 million people, so I really have to think about how many Norways is really these figures. I mean, we have to try to think like that. And also, as you said, all the internally displaced, but really also how long people are displaced. I mean, what we see is that the displacement lasts for 10 years for internally displaced and 20 years for those externally displaced. That's a lifetime. That's almost like a generation. And also think about where they are displaced. It is really the low and middle income countries. It's not the Norway. We fight, about should it be 20,000, 100,000? There are some dimensions here, and I think, do we do enough to really sort of make this real for ourselves? We cannot send everybody to the field. We cannot but maybe there is something still to do with our advocacy. I think so, because it's difficult to really grasp these things. So of course, it is a big question mark for me, and I know that's what all of us are working on. We know that it has been a lot of great jobs doing in emergency. But still, in 2025, it's not really understood that NCDs need to be part of the emergency response. And I'm going to sort of reflect a little bit on what we have done and what I could do from my position together with all of you. So first of all, I think COVID actually helped us. And as we know, people with diabetes were really at high risk. They experienced the same as we heard from the voices, but just even more. And more people that usually got a certain amount of insulin and care suddenly didn't get anything. And we know it was like 2 to 3 times higher numbers of people dying during COVID. But actually COVID helped us at WHO, because it was the first time we can show that emergency, pandemics, disasters is not only about infectious diseases. And of course, it's not a competition. We have never argued that we should stop doing the things we always did. But it was a shock, I think, to all of us when we looked through the national preparedness plan, and we found, this was in 2023, I think, we found like 16 countries that actually mentioned NCD, and most of the time it was only a mentioning, and maybe there were one disease mentioned, but it was very far from really an integration. I don't know the numbers now, maybe Kiran knows. I hope we have done this exercise again. I think it's a way to measure how people are really thinking about it. And what we learned as well is that even if we have humanitarian organizations that understand, it's still so fragmented. And it's so many ways to do it. It's not systematically. I think a lot have happened now the last 2 years because of the very good collaboration that has sort of continued after COVID, I would say, between the emergency organizations and especially in WHO, where we saw the emergency division started to work with non-communicable diseases, but also maternal and child health in a different way. We saw that it was a significant fragmentation. So what could we do? So the first thing I was able to do was to hire Slim Slama. And I think many of you know him. At the moment, in time when I got him, it was a big blessing because we had tried together back in 2013 to raise the agenda. So he came, COVID came, and I mention this because it is very often about people. People like Sylvia, people like many of you in this room. And let's be clear about that. Why don't we celebrate that a little bit more? It's excellent. You know, the Boston Declaration would never have happened probably without you and the board and everybody. So what we saw was it was still a patchwork of organizations and there were no sort of structure. And what we were able to do was to get one paragraph when we got the diabetes resolution back in 2022. Actually, a full paragraph mentioning that the access to care and treatment for diabetes patients should also happen during humanitarian crisis. And that was really a great build-up. I know I have not more than some few minutes more. And we also we managed to really get the members of the World Health Assembly to get engaged, and they asked us to come up with recommendations. And that's the way we do it. I mean, the member states knows that this is a problem, sort of, but very often we need from WHO, now I'm an NGO, I'm with St. Jude's Research Hospital. We also have a role to play in evacuating children from Gaza and Ukraine. We need all of us, academic institutions, UN agencies, but also NGOs, to remind the member states that they need to request for advice. So that happened. And I think what we see today is that we have a golden opportunity because we have for the first time 2 full, very clear paragraphs in the political declaration. Yes, I know, it's not yet fully endorsed, and it will be happening. I am very hopeful, and nobody has actually attacked these paragraphs. So I think it will stay. I say Alison here from NCDA, she will probably be able to tell you more about that if you are curious about this. But I think what we did together, first the diabetes resolution, of course, building on all the work you did. And I think also I would like to mention, for me, that was the first sort of really aha moment when Peter Maurer from the Red Cross said in a big meeting to a lot of business people as well that actually the reason for amputations in refugees camps was not because of landmines, but because of lack of access to insulin. And I think these kind of stories helps us, right? So in the political declaration, and I'm going to read these 2 paragraphs because I think it's important that this is a context for this meeting. So one of them reads, integrate non-communicable diseases prevention and control, and also, of course, mental health and psychosocial support into emergency and pandemic prevention, preparedness and response, and humanitarian response framework to contribute to resilient and responsive health system capable of effective emergency preparedness and response. So that was the first one. Very, very clear. So now it's up to us to make everybody accountable and actually do measures that can help us to see this progressing. And the second is the strengthening and the design of implementation of policies, including a resilient health system and health services and infrastructures, to treat people living with NCDs and prevent and control the risk factors in humanitarian emergencies, including before, during, and after natural disasters, with a particular focus. So that's the 2 paragraphs, and it's mentioned a couple of other times as well, but these are among the decisions. So people, we need to take this seriously, because this is the heads of states and governments. They came together. They had very strong commitments in their interventions. We need to build on this. Of course, we could say, what does it matter? Why do we struggle so much? But honestly, this is the highest level of commitment, and it's really up to us to be accountable together with them and do what is needed. So I just want again to end with saying that thank you. I think the global high-level meeting we did in Copenhagen, where I think most of you were, 80 member states, it was one of the big moments where we stopped having the silos, this is non-communicable, this is communicable, this is acute, this is protracted. I will never forget Mike Ryan, a great guy. He had, I think, the last say in the conference, and he said, let's agree it's a continuum, and we need to think differently. It has to be a preparedness, really looking through the whole health system, and the preparedness is the most important, and I took that to heart. So I trust that together, this was the 5th convening. So in the 6th convening, I hope we will have some figures that some of these commitments actually happened and that they served the people living with and at risk for diabetes. Thank you very much.
Thank you so much, Bente. That was an amazing summary and very much resonated with me. The part about we all have a role to play no matter our background. I certainly feel that way, being an endocrinologist based in Boston. What do I know about humanitarian settings? But I think having seen in certain experiences what diabetes care looks like in many countries is devastating and unacceptable. So for each of us to find our role, and it's not a competition. I think that's also very important, right? The whole human with all the health conditions. It's not diabetes over something else.